Hello again. These next two lectures will be about seizure disorder and anti-seizure medications. Approximately 2 to 3 million people in the United States, that's about 2 to 3% of the population, are affected by seizures. The incidence of seizures is highest in children under 10 and adults over 70. A seizure can be defined as a convulsion or an abnormal neurological event caused by the sudden discharge of excessive electrical activity in the brain. The word convulsion means that the muscles of the body contract and relax spasmodically. There are many types of seizures that do not involve convulsions. A seizure may occur as an isolated event, such as a very high fever, alcohol or drug withdrawal, electrolyte imbalances like low blood sugar, or kidney disease. In these cases, once the underlying problem is resolved, there will be no more seizures. This person does not have a seizure disorder. The person with a seizure disorder has seizures that recur in a chronic pattern. Seizure disorder is also known as epilepsy. The person with a seizure disorder has sudden, brief attacks of altered consciousness, altered motor activity, altered sensory phenomena, and or inappropriate behavior. And it's all caused by the excessive discharge of cerebral neurons. So what happens is a group of abnormally firing neurons start a seizure, and this is called an epileptogenic focal point. Whatever part of the body is controlled by the epileptogenic focal point will react abnormally. So it's a focused group of nerves. So the etiology of seizures. Seizure disorders are not uncommon in children and may occur for a variety of reasons. Febrile seizures often occur during childhood. An acute febrile convulsion, which occurs because of a high fever, is not considered an epileptic disorder. It is an isolated disorder, and once the fever is resolved, the seizure activity will stop. Epileptic seizure disorders in children, which are recurrent and chronic, are classified as primary or idiopathic seizures or secondary seizures. Idiopathic seizure disorders have no known cause, but a secondary seizure disorder results from a secondary cause, such as infection, head trauma, hemorrhage, or a congenital defect. Secondary seizure disorders are more common than idiopathic seizure disorders in children, and the onset is usually between 4 and 8 years of age. Any seizure that occurs before 2 years of age are generally due to birth defects, and these have a very poor prognosis. Interestingly, childhood seizures often stop at puberty or after puberty. Seizures that have their onset in adulthood are most likely due to a secondary cause, such as a head injury, brain tumor, brain infection like meningitis or encephalitis, a stroke or a CVA, hypoxia, or sleep apnea. There are many categories of seizures. Seizures are categorized, and this is important to remember these because it gets confusing. Seizures are categorized as partial or generalized. A partial seizure involves only one part of the brain, and the person remains conscious and the symptoms are localized in one hemisphere of the brain. So, partial seizures involve only one part of the brain. The person remains conscious. The symptoms are localized in one hemisphere. A generalized seizure involves both hemispheres of the brain, and the patient usually loses consciousness. Sometimes there is an aura before a seizure. An aura is a warning sign that a seizure is going to happen before it actually happens. The person smells unusual smells no one else can smell. They see bright lights, things like that. We're going to talk about two different types of partial seizures. First, we'll talk about simple partial seizures, then we'll talk about complex partial seizures. And then we're going to talk about 5 types of generalized seizures. Absent seizures, febrile seizures, akinetic seizures, myoclonic seizures, tonic clonic seizures, and we'll also touch upon psychological seizures. So first, partial seizures, which are also called focal seizures. Partial seizures are also called focal seizures because the focal point is one part of the brain. Remember, partial seizures don't only involve one part of the brain or one hemisphere of the brain. There is no loss of consciousness. The person remains conscious. So first we have simple partial seizures. A simple partial seizure may be motor or sensory in nature. Simple partial seizures typically last 20 to 30 seconds, and the person remains totally conscious throughout. If the simple partial seizure involves motor function, there'll be an uncontrollable jerking or twitching of a finger, hand, foot, leg, or the face. The Jacksonian march may occur. So, the symptoms may begin in the hand, and the hand starts twitching, and then it moves up the arm, and then into the face, and then it marches down the body. So it can affect an arm, a leg, but it's all on one side, and it's very, very quick, like a march. That's the Jacksonian march. That also, that would be a motor component, but there can sometimes be a sensory involvement. Sensory involvement when the person is having a simple partial seizure is they see bright lights, they smell odors, or they describe a tingling sensation, but there's no cause. Complex partial seizure. Now, in a complex partial seizure, the patient is going to lose contact with his surroundings for a minute or two, but he is perfectly conscious. However, his level of consciousness is altered. At first, the person appears to be staring blankly, and he begins to perform what they call automatisms, which are purposeless movements, and he begins to utter unintelligible words. He cannot understand what you are saying, and he's going to resist any help. He'll push you away, he'll kick you, he'll scream. So they're going to be, the person is unaware of their surroundings, they're totally conscious, but they do these automatisms. So they have movements. They'll be going around and around and around in a circle. They may be smacking their lips. They may reach down and pick things off of the ground, like this paper clip, or maybe something that isn't there at all. But they do this continually for the length of the seizure. If you try to interrupt it, they are not going to understand you, and they will get very agitated if you try to stop them. Automatisms, again, are things like lip smacking, picking things up that don't exist, pulling at your clothing, or pacing aimlessly. They last for less than a minute, but the mental confusion continues 1 to 2 minutes after the motor component of the seizure stops. The person may not remember what happened. There may be an aura, such as an unusual smell or being very emotional just before the onset of the seizure. Remember that even though there is an altered level of consciousness, the patient is considered conscious. Many times, people that have complex partial seizures are misdiagnosed with a major mental illness instead of a seizure disorder because they're not very common and people don't know what they're seeing. I have seen people that I have thought were probably having complex partial seizures and they've been diagnosed with a mental illness, but that's part of their schizophrenia. So you have to be aware of that. Now let's move on to generalized seizures. Generalized seizure, in order to be considered a generalized seizure, at least one of the two signs must be present. First, the seizure is going to involve both hemispheres of the brain. Number two, the person loses consciousness. The first type of generalized seizure I'm going to talk about is called a myoclonic seizure. Myoclonic seizures affect a small number of children and adults. The word myoclonic means a jerking movement. The cause of myoclonic seizures is idiopathic. There isn't a known cause. The seizures happen most often right after awakening or while falling asleep. The seizure is very brief, 1 to 2 seconds, and the person experiences twitching, jerking, jumping movements of a muscle or a group of muscle. The seizure happens simultaneously in the same muscle or groups of muscles on the same side of the body. Thus, both hemispheres of the brain are affected. So if it's happening in this arm, it's going to be happening in that arm. So for that reason, it is considered a generalized seizure, even though the person did not lose consciousness. Remember, they only have to have one of the two criteria. Both hemispheres affected, or they lose consciousness, or both. Myoclonus, some of you may have experienced this, I do, but myoclonus is experienced by people who do not have seizure disorder. The sensation of myoclonus happens in the early phases of falling asleep. So as you're falling asleep, you feel a mild jolt of a muscle in the leg or an arm jerks or twitches momentarily. So that happens to me when I'm just about ready to fall asleep and my legs or arms will start to twitch a little and then it stops. Myoclonus is also experienced when we hiccup, because hiccups are myoclonic jerking motions of the diaphragm. So if you've ever experienced myoclonus, you have a good idea of what a myoclonic seizure is like. The next type of generalized seizures are what we call absent seizures. These absent seizures were formerly called petit mal seizures, and you still hear them referred to that way. Absent seizures are more commonly seen in children. They're very brief, lasting only 5 to 20 seconds. During this brief time, the child loses consciousness and will not remember having the seizure. What happens? Activity stops abruptly. Whatever the child was doing at the time will just stop. So the child may be coloring in this picture. They have a seizure. The activity just stops, just like that. When the seizure is over, this child will just as abruptly resume whatever they were doing before the incident. So, I'm coloring in. I have my seizure. My activity abruptly stops. Seizure's over. And I go right back to what I was doing before I had the seizure. During the seizure, if you watch the child, there's going to be rapid eyelid fluttering, really rapid, at the rate of 3 per second, and rapid eye blinking. I can't even blink that fast. The child's going to stare ahead blankly, and there's lip twitching and smacking. The child does not fall. The child does not have a convulsion. When the seizure stops, the child is instantly alert and conscious. He begins his conversation or activity exactly where he left off before the seizure happened. The child is unaware of the seizure, but may report that he feels like he lost time. Without treatment, the child may have 50 to 100 absent seizures daily. So they, in fact, lose a lot of time. These seizures often stop when the child reaches their teens. Another type of generalized seizure are febrile seizures. Febrile seizures occur with a high temperature, with or without a neurological infection. They usually affect children between the ages of 3 months to 5 years. They're usually brief, solitary, tonic, clonic seizures. And I'll explain what that is in a little while. And they only last a few minutes. However, in rare cases, the febrile seizure may last 15 minutes and occur more than twice in 24 hours. That child will be hospitalized. Now, febrile seizures are included under generalized seizures because the child does lose consciousness and they do have a convulsive seizure. However, it's not an epileptic or disorder because they are based on fevers and probably acute incidents. The next type of seizure is the akinetic seizures or atonic seizures. And the kinetic or atonic seizures are brief generalized seizures seen in children. They cause a momentary loss of consciousness, loss of muscle control, and loss of postural control. They're kind of frightening when you see them because the child often falls to the ground abruptly, and this can result in serious facial, head, or shoulder injuries. And akinetic seizures may recur frequently, especially in the morning. Infantile spasms. Infantile spasms occur between 3 to 12 months of age and almost always indicate a cerebral defect. They have a poor prognosis even with treatment. Infantile spasms are twice as common in boys. So the seizure happens, but it's preceded or followed by a sharp cry. The muscle contractions are sudden, brief, and symmetrical, and the baby starts rolling their eyes. The infant doesn't always lose consciousness, although there may not be a loss of consciousness. Infantile spasms are considered generalized seizures because both hemispheres of the brain are involved. Now I want to talk about what you think of when you think of someone with a seizure disorder, and that is called tonic-clonic seizures. This is what used to be called a grand mal seizure. So tonic-clonic seizures are what comes to all our minds when you think of a seizure disorder. Tonic-clonic seizures are the most common seizure disorder that are seen in adults and children. The patient that suffers from tonic-clonic seizures is at high risk of injury because the seizure may develop suddenly and the patient loses consciousness and falls to the ground. Therefore, these patients risk serious potential injuries such as head injury, fractures, burns, or motor vehicle accidents. Tonic-clonic seizures follow a predictable pattern. First, you have the aura. The patient experiences an aura. An aura can precede the seizure by an hour, or it may be only for several seconds. During the aura, the patient experiences olfactory, visual, auditory, or taste sensations or hallucinations. Specific examples of auras are seeing bright lights, hearing voices or sounds that no one else hears, strange smells that do not exist, feeling numbness or tingling, feeling separation from your body, or anxiety or fear for no reason. Auras are considered subjective symptoms that are reported by the patient because nobody else can observe them. After the aura, a loud cry may be heard as air is forced out of the lungs. The patient loses consciousness and falls to the ground. Now they're in the convulsive stage. There goes my candy cane number 2. The first phase of the seizure is the tonic phase. During the tonic phase of the seizure, all the muscles are rigid. The arms and legs are extended, the jaw is clenched, the back is arched, and the neck is hyperextended. The pupils are fixed and dilated. Breathing briefly stops for a few seconds, and momentarily the patient is cyanotic. The tonic phase of the seizure usually lasts from 30 seconds to 1 minute. Then the patient goes into the clonic phase of the seizure. The tonic phase of the seizure is immediately followed by the clonic phase. During the clonic phase, the muscles simultaneously contract and relax rapidly. The eyes roll back. The patient bites the sides of his jaw or cheeks and tongues. The muscles in the jaw contract. Frothing at the mouth may occur. The patient is often incontinent of bladder and bowel. The clonic phase usually lasts 30 seconds to 1 minute. The average length of the entire seizure, including the tonic and clonic phases together, should be 1 to 2 minutes. So, we've gone through the aura phase, the tonic phase, and the clonic phase. Next, the patient goes into the post-ictal phase. So when the seizure ends, the patient is unconscious for up to half an hour. all convulsive activity stops, and the patient lies very, very still. He slowly regains consciousness and may be disoriented and confused when he wakes up. After awakening, the patient often complains of headache, muscle ache, and fatigue. The patient often sleeps for hours after regaining consciousness, and amnesia of the events of the seizure is a common occurrence. Now, briefly just talk about what's called status epilepticus. Status epilepticus is a medical emergency that is life-threatening. Without immediate intervention, status epilepticus can lead to permanent brain damage or death. Status epilepticus is defined as a continuous period of tonic-clonic seizures lasting 5 minutes or longer. In many cases, a series of tonic-clonic seizures occurs without a period of normal neurological activity. So it just goes from one seizure into another, into another. The brain then becomes depleted of oxygen. There's impaired ventilation, glucose depletion. Remember, you need glucose for your brain to function properly. The patient goes into a state of total physical exhaustion and respiratory distress. The first line of treatment is to insert an airway to make sure that the patient has respiratory patency. An IV is started and IV anticonvulsants are administered. IV Ativan or lorazepam or Valium, also called diazepam, is usually the first anticonvulsant of choice. But because Ativan and Valium are short-acting, their anticonvulsant properties are short-lived. A longer-acting anticonvulsant, such as IV Dilantin, is administered to establish longer seizure control. Status epilepticus can be triggered by abrupt discontinuation of seizure medications. In fact, that's the most common cause. Other causes are acute head injury or hypoxia. One other type of seizure that does occur that I'm going to mention ever so briefly are psychological seizures. So these are seizures that can occur in people that have no seizure disorder and no underlying medical conditions, but it's due to anxiety and extreme stress. The seizure looks like a tonic-clonic seizure and is often misdiagnosed. The seizures, though, have nothing to do with misfiring neurons, but are brought on instead by hyperventilation. So you're hyperventilating, you're not getting enough oxygen, it causes you to have a seizure. So it's not a neurological problem, it's a psychological problem, and it usually happens when somebody is in a high state of stress or high anxiety. So what are we going to do to help people with seizure disorders? First of all, there's interdisciplinary care, would be diagnostic testing. That would be an MRI and CAT scan to rule out underlying causes, such as brain tumors, stroke, or hemorrhage. A skull X-ray will show if there's any fractures. Lab work will detect if the seizure was brought on by an electrolyte imbalance, like low blood sugar, kidney disease, thyroid disease. And an EEG helps determine the type of seizure and the type of seizure and the leptogenic focal point in the brain. Medications are used to treat seizures, and I'm going to talk about that separately after this lecture. Surgery. Surgery may be done if the patient is non-responsive. Surgery may be done if the patient is non-responsive to seizure medication. Several medications must be tried before the patient is eligible for surgery. During the surgery, the patient usually remains awake while the surgeon maps out the area of abnormal activity so that the abnormal tissue can be removed. You need the person awake so they can cooperate and you can see the neurological activity as it's happening. Another treatment is what's known as the ketogenic diet. That's a diet high in fat and low in carbohydrate. Because of the low carb intake, the body's going to use fat as their primary fuel. It's a diet that's very unpleasant to the palate of children and often has to be discontinued because the child cannot adhere to the diet restrictions. You can read more about that in your book. Now I'm going to go through the nursing process in regard to seizure disorders. First of all is the airway. So, hospitalized patients are going to have suction equipment at the bedside because the patient may need to be suctioned to prevent aspiration. Make sure to have oxygen equipment at the bedside because seizures can cause hypoxia. If needed, oxygen is administered via face mask. Loosen the clothes around the neck because loosening the clothes around the neck is going to help maintain a patent airway. Turn the patient on their side in the recovery position so the tongue can fall away from the airway. The side-lying position also facilitates drainage of secretion. So what do you want to have at the bedside? You want to have suction equipment and oxygen. Turn the patient on their side and loosen their clothes. There was a time when they recommended that you put a padded tongue blade in the mouth of a patient having seizures. That's a true taboo today. Never put anything in the patient's mouth because it can obstruct the airway as well as breaking the person's teeth. So found through evidence-based practice that the tongue blade actually caused more harm than good. Injury. If you're taking care of someone in the hospital, keep the bed in a low position. Never restrain the patient. That's going to make it worse. They may get hurt. The bed should have padded side rails, a seizure precaution and safety precaution bracelet, and there should be a sign over the bed. If a seizure starts and the patient is sitting or standing, gently lower them to the floor and remove furniture and other obstacles in the immediate area. Place a pillow under the person's head. And patients that have frequent seizures often wear protective headgear. Again, don't try to keep them still or hold their head. Just make sure that the area is safe and let the seizure happen. Anxiety. The patient may have anxiety and fear about seizures. Educate the patient about the condition. Understanding the disorder helps alleviate their fears, worries, and misconceptions. Refer the client to the appropriate support groups and local information agencies. After the first seizure, people are often in terror about having a second one or having anything happen in public. So they do need a lot of understanding and support. Documentation is very important. The nurse stays with the patient during the seizure and after the seizure until the patient is stable. So they do not leave the patient to document until the patient is stable. You should have a pad and pen with you in your pocket so you can make notes. You want to note the time of onset, the duration of the seizure, and the character and movements of the body. What was happening with their extremities, their head, their trunk. Document any incontinence or tongue or cheek biting. Carefully watch for respiratory distress and suction and administer oxygen via face mask as needed. After the seizure, check PERLA, vital signs, and assess the patient for injuries. Be aware of and document the patient's reaction following the seizure. Once it is safe to leave the patient, a progress note is written. So, you want to document the time the seizure begins, the duration of the seizure, in other words, how long did it last, any precipitating factors or triggers, the type of seizure, the part of the body involved, urine and bowel incontinence, apnea or cyanosis, loss of consciousness, any automatisms, and post-lictal phase description, so after the seizure. You need to teach the patient and family about the disorder to help teach the patient and family about seizure disorders in order to help dispel their misconceptions. There is still stigma to seizure disorders, so people need a lot of support again. Injury. Certain activities that are dangerous with a seizure disorder, such as driving a motor vehicle or playing in contact sports, may be restricted. There are legal restrictions regarding driving or operating a motor vehicle. In Massachusetts, a person with a seizure disorder will be eligible to drive after a seizure-free period of 6 months. They need a detailed physician's report and a physician's recommendation that they can drive safely. The nurse needs to reassure the patient that once the seizures are controlled with meds, he will be able to drive again. Some sports are dangerous. Any sport where the child could suffer from a serious fall should be avoided, like rock climbing, rope climbing, any of those kind of sports, and contact sports are considered with caution. Medication, you want to teach the patient and family about the action, frequency, and side effects and special considerations of the meds being used. Take the medication at the times prescribed and remind people that abrupt discontinuation of medication can lead to status epilepticus. So never stop taking your seizure medicine abruptly. The patient should keep all medical appointments. Certain medications require lab work to determine a safe and therapeutic range. Too high a dose can lead to toxicity, and too low a dose will cause breakthrough seizures. Blood work will also detect any adverse reactions, such as anemia, elevated liver function tests, kidney problems, or bone marrow depression. Important teaching points. Teach family and patient to avoid injury at home by not smoking in bed or when they're alone. Install grab bars in the bedrooms and bathrooms. Take showers instead of baths to prevent drowning. Keep the bedroom and bathroom doors unlocked in case there's an emergency. Avoid activities that require alertness and coordination until the medication levels are therapeutic. That would be climbing or contact sports. And they should also be cleared by a physician before doing these activities. Wear a MedAlert bracelet with diagnosis and medication listed. Teach the patient to keep a diary noting the date or a duration character and post-seizure activity. This is called a seizure record. And I do have one that I use in a hospital. I'll include that in your packet with the outline. Always bring the seizure record to your neuro consults. Avoid alcohol and caffeine. Avoid triggers like flashing lights, stress, fatigue, and fasting. The National Epilepsy Foundation is an excellent resource. There are also support groups locally that you can refer patients and family to. The nurse needs to continually educate the public about the truths and misconceptions of epilepsy. Teach people about the medications, the actions, the doses, the frequencies, and the side effects. Take medications as prescribed, and never abruptly discontinue the meds, which could lead to breakthrough seizures and status epilepticus. When do you call 911? Now, if a person has a seizure disorder that they have had for years, you do not have to call 911 every single time they have a seizure. However, if it's the first time a seizure has occurred, call 911. If the person has a seizure that lasts 5 minutes or longer, call 911, regardless if it's the first seizure or they have a history of seizures. Call 911 for status epilepticus, and call 911 for medical complications like an injury or airway disturbances. Remember what you're going to do. I'm just going to give a quick listed review. To keep the airway open, have suction equipment, oxygen equipment handy, loosen the clothes around the neck, turn the patient on their side, and never put anything in the patient's mouth. For injury, the bed is in the low position. Never restrain the patient. Padded side rails. Seizure precaution signs, safety precaution bracelets. Gradually lower the person to the floor if they're having a seizure. Remove the furniture in the immediate area. Put a pillow under their head, and they may have protective headgear. For anti-anxiety, educate the patient. Knowledge is probably the best leveler of anxiety. Listen to the patient and refer them to a support group. Always stay with the patient during a seizure. And I put, at the end of this lecture, I wrote a choose all that apply question for you guys to do. I'll read you the question to end this part of the lecture. So, a patient begins to seize while the nurse is conducting an assessment. Place these actions in the sequence that the nurse should do them, and state your rationale. So, what do you want to do first? And these are the 6 things. Clear the area of objects that could cause injury, loosen the gown, turn the patient on their side, pad the side rails, provide supplemental oxygen, or place a pillow under the patient's head. And that is the end of that lecture. This little question will be in the packet. It's mostly for practice and review. It's not really in all that apply now that I think of it. It's a list in order of priority. Take a break and we'll finish up with anti-seizure meds.